Thank you for logging on to today's webinar, How to Use SBIRT with People Experiencing Homelessness Who Smoke Tobacco. My name is Marla Kaufman, and I'm the Communication and Health Promotion Associate at IRETA. I'll be moderating our webinar today. I would like to go over some quick housekeeping items about how to use the WebEx technology and how to access continuing education credits. First, we would like to encourage you all to participate in today's webinar in a few ways. If you have questions for our presenter or are experiencing any technical difficulties, please use either the chat function or the Q&A panel to communicate your questions. Our presenter, Jim Winkle, will take questions at the end of the webinar. Feel free to submit your questions through the chat or Q&A box at any time. This webinar is approved for 1.5 PCB and/or NADAC credits, which are free. A certificate of attendance will also be available to download from your MyIRETA account. Please take note, it will take up to 48 hours for your CEUs and certificate to be available in your MyIRETA profile because we have to cross-check your attendance records with WebEx following the webinar. After the webinar, you will receive a follow-up email. This email will include a link to an evaluation form for the webinar, as well as more information on how to access your certificate of attendance and continuing education credits. We may send you an additional email to remind you of the evaluation. There's currently a poll on your screen, so if you're just logging in now, please fill that out. I would like to introduce today's presenter. Just a second. Jim Winkle, MPH, has trained hundreds of medical and behavioral health professionals on how to address substance use with patients and clients. As the creator behind the SBIRT Oregon website, Jim has designed screening forms, clinical tools, and training videos used by professionals across the country. Okay, Jim, I will close this poll and hand things over to you.
Thanks, Marla, and welcome everyone. Thanks for joining me today. We have an hour and a half for this presentation, and like Marla said, I will end a little early, so there's time for questions and comments. My background in this, I've been doing SBIRT for more than 10 years, first at Oregon Health and Science University in the Department of Family Medicine, where we had a grant to train medical residents how to do SBIRT in primary care. We got a second grant where we expanded their training to social worker students, licensed professional counseling students, and then we implemented SBIRT in 7 different primary care locations. Since then, I've been doing this as a consultant, and I also do SBIRT training for community organizations, Boys and Girls Club, other medical settings like paramedics, school-based locations, teachers, counselors, etc. So I have quite a bit of experience doing SBIRT training. I'm a little bit new to focusing on the population of people experiencing homelessness, but I've given this presentation before in a different format. I wanted to expand its audience. So today we're going to focus specifically on how SBIRT can help people experiencing homelessness who use tobacco. The SBIRT Oregon website is a website I manage. You can use this website as a resource to download these training slides or other tools on the website. Okay, so let's go to the slide here. Why is this relevant? Whenever we want to apply the SBIRT method to any substance, it should meet these criteria. And smoking among people experiencing homelessness definitely falls under these. So tobacco use is definitely prevalent, as we'll see, among this population. As everyone knows, probably, there's lots of morbidity and mortality and healthcare costs associated with tobacco use. I'm going to look at 2 screening instruments, 2 validated screening tools that work well with this population when we want to detect a tobacco use disorder or just risky tobacco use. And then the interventions as part of SBIRT need to be effective, which means they should be evidence-based. And brief interventions are towards tobacco use. They're not expensive to deliver, and they're feasible, meaning that brief intervention can be done in 5 minutes, can be done in 10 or 15 minutes, but you don't have to be a therapist who has an hour with a patient or client. You can do this in a service center like a homeless shelter. You can do this on the street. So that's how SBIRT and why SBIRT applies to tobacco use. So a few slides here on some statistics. So obviously, unfortunately, tragically, people who experience homelessness in this country are not a small population. You can look at it from a snapshot angle or incidents over a lifetime. So that first bullet point there, when people count people experiencing homelessness, they can do it in a single count. So in January, over 500,000 people in the US, January 2022, were experiencing homelessness. So about 18 out of every 10,000 people. Over a lifetime, people sometimes go in and out of experiencing homelessness. So on average, about 4.2 million youth and young adults experience homelessness. And then that's not evenly distributed. That's if you live in this country as a person of color, or you're a parent or LGBTQ+, you're more likely to experience youth homelessness. And then tobacco use among this population, where there's adolescent or adults, obviously very high, at least 57%, maybe as high as 82%. And unlike the general population, where we've made a lot of progress lowering the rate of tobacco use in the last few decades, that has not changed with people experiencing homelessness. And that rate, as you can see, compared to the general population, is more than 5 times higher. So in the general population, it's around 11% nowadays, but people experiencing homelessness, it's more than 5 times that. So obviously this is a very prevalent behavior. And then this is not a light tobacco use. Average in this population is 10 to 13 cigarettes a day, and 1/3 of these folks often use a cigarette within 30 minutes of waking up. So a highly prevalent behavior here. And then when it comes to morbidity and mortality, as we probably know, there's a lot of premature death that happens among people who use tobacco. But when you compare the smoking-related deaths between homeless and marginalized housed people to people more stably housed, it's double the rate. So the deaths that are related to smoking happen twice as much as they do with people not experiencing homelessness. And then there was a study in Boston at a service center, a shelter, where they served 28,000 homeless adults, and they tracked various things, and they found out that cancer was the second leading cause of death overall, and the leading killer among adults 45 years or older. And that was cancer of, the lungs, the trachea, the bronchus, things strongly related, of course, with smoking tobacco. So people experiencing homelessness, like anyone, are dying prematurely from using tobacco. And then morbidity, there's all sorts of things that can go wrong beyond just like lung cancer and cancer in general. It impacts our health in many ways. This is why we want to address this with this population. And of course, there's comorbidities or multimorbidities going on. Substance use disorder, whether that's also alcohol or
Hi, Jim.
Alzheimer's.
You
Oh,
were
sorry.
just oh, it's okay. You were just breaking up a little bit, but it seems like you're back now. So
Thanks.
yeah.
And then people experiencing homelessness, less likely to get regular medical care. So when we screen for tobacco use, we will run into other comorbidities. And that's why when we look at the screening tool, I recommend using the TAPS screening tool, which also screens for these things. So there was an article that came out in the New England Journal of Medicine a few years ago that really addresses what the problem is and how we can address it. And it points out that all these comorbidities that are going on, the other substance use disorders, and the life circumstances of people who are homeless and use tobacco have fueled a fatalistic attitude among healthcare professionals towards addressing tobacco use in this population. So there is kind of this common attitude out there that, well, if someone is experiencing homelessness and other substance use disorders, maybe the least of their worries should be tobacco. But that is a fatalistic attitude for a number of reasons. One is evidence suggests that many people experiencing homelessness are interested in quitting. And we'll see some numbers behind that. However, their confidence in the ability to quit is low. And that indicates that we should have interventions that support smoking cessation. They're needed in this population. If someone tries to quit on their own, they have a very small chance of succeeding. If they try to quit with treatment, it's much higher. And so this population deserves to have assistance when they're interested in accessing treatment. So what are the numbers? According to this study of Dr. Maya, 40 to 50% of people experiencing homelessness made a quit attempt in the past year. However, they don't have access to services like the general population as much, so many of their quit attempts are unassisted. So without help, without treatment, you can see the rate there, the successful quit rate is quite low. So there is an urgent need for cessation treatment in service settings or in any setting where you can reach people experiencing homelessness. So if there's this need for treatment, a brief intervention, as we'll see, is essentially a way to explore someone's motivation to change their behavior, which means to access tobacco use treatment. What is the evidence? Well, someone with a certain condition, is there evidence that the brief interventions are effective, the screening? And they concluded that in a general population, at least, whether it's pharmacotherapy or behavioral interventions, either one of those or combined, the evidence behind supporting the effectiveness of those interventions is substantial. Now, we don't have very good evidence or yet specific homelessness. So people experiencing homelessness deserve help when they're interested in quitting. And what can that help look like? These are the evidence-based ways of helping people quit smoking. And one of them is motivational interviewing. I bolded that because that is the brief intervention that is part of SBIRT. So when we want to help someone access one of these kinds of therapies in order to stop smoking, we do that through a brief intervention, through motivational interviewing. And so if these are the ways we can help people stop smoking, how we can do that? First, we should screen them, meaning identify who has a tobacco use disorder or who just has risky tobacco use. Those folks who are positive, we should do a brief intervention, which is essentially motivational interviewing when you don't have a whole lot of time. And then people who are ready to access treatment, we should proactively help them access that treatment. And that is the SBIRT method. So SBIRT does apply to people experiencing homelessness who use tobacco. And SBIRT applies to many kinds of substance use. And what it is, it's a preventative service because we're trying to reach people before they develop disorders. And if they already have a disorder, we're helping them access treatment if they're ready for it. So this is the SBIRT method, and I'm going to demonstrate what this looks like specific to this population and to tobacco use. So screening. Screening just means that we want to identify people without being suspicious first what is going on. The prevalence rate of smoking among people experiencing homelessness is high enough to justify having a policy at your service organization or just as an individual that you always screen people for tobacco use as part of a regular protocol of some kind. And when we screen people for substance use, we're trying to find out which of these three categories they fall into. And we use a pyramid here to kind of demonstrate that most people are low or no risk. But the other folks who we want to help are either using tobacco at a risky level or they have a tobacco use disorder. And risky just means frequency of use. That's how we define if someone either doesn't use it or they use it at a low risk level or risky. Disorder, if someone has a tobacco use disorder, that is addiction, how do we define that? It's by number of consequences. So what a screening tool does is asks questions, you come up with a total score, and that score correlates with one of these categories. What are the consequences that define a tobacco use disorder or any kind of substance use disorder? You don't need to memorize this. You can Google this if you want, but with the DSM-5 here, this is how we define addiction. This is how we define substance use disorders. Technically, if you experience at least 2 of these consequences in the last 12 months, you would be diagnosed with a mild substance use disorder. 4 or more consequences would be moderate, 6 or more would be severe. So this is how we define addiction in 3 different levels. And so as you can see here, if you have consistent cravings and urges to use the substance and you keep using it, even though it puts you at risk, if you need more and more of the substance to get the same effect because you're building tolerance, you're developing withdrawal symptoms when you don't use the substance, these are all repeated negative consequences that people experience when they are living with a substance use disorder. And this is what a validated screening tool will tell us is likely going on when it's used. Excuse me. So I keep saying validated screening tool. Why is it important to use a validated screening tool? Why not just ask people, do you smoke and how often do you smoke, and just come up with your own questions? Well, the reason is if we want to use questions with some level of certainty that they'll elicit honest answers and accurate answers, we should test these questions. And there's people who specialize in coming up with questions that most likely elicit honest answers, and they test them against a gold standard. And if the validation is high enough, we call them a validated screening tool. So they're evidence-based, they've been tested. And it quickly tells us what category of substance use people fall into, risky or disorder. It ensures that we ask the same questions across different people in different populations. And it reduces bias, meaning that if we didn't use a tool, we might ask questions in a different way based on someone's gender or their race or their age or some other status. And then we're not doing it consistently and bias comes out. So if we have a policy of just using a validated screening tool universally and it's standardized, it takes care of that. And then if you work for an agency that would like to know how many times you screen people for substance use, what category they score into, you're collecting data, it's great to use a validated screening tool because it makes your data that more quality. So what tools should we use if we want to find out with anyone, but especially with people experiencing homelessness, we want to find out what level of tobacco use they're at. I recommend the TAPS tool for adults and the CRAFT for adolescents. So we're going to look at both these tools. You can download them from the internet. You can use them in different languages, and these are both validated tools. So let's look at the TAPS first. This is meant for adults. Sometimes 18 and over, sometimes 21 and over. It's kind of up to your judgment there. There's some overlap. It screens for tobacco, but it also screens for other substances that are used at a higher rate among people experiencing homelessness. It screens for alcohol, abuse of prescription medication, methamphetamine, and other drugs. So it's kind of an all-in-one tool here, which makes it a great tool for this population. Specifically for tobacco use, the questions that ask about that, that's pretty good sensitivity and specificity. That's good validation. It's kind of a skip pattern based on how many questions you ask. So at least someone will answer at least 4 questions, but as many as 14, depending on how much substance use is going on. So that means this tool can be delivered in 2 or 3 minutes tops. And it can be delivered by reading the questions yourself, which is probably better because if your client has literacy level that is not enough for reading the paper, you can just read it yourself. But you can hand them the tool on a piece of paper, or if you have a tablet, there's an online electronic version of this tool where someone just taps their answers. Or you can give it to them on or via interview where you read the questions and you mark down the answers. So what are the questions here? These are just the tobacco questions that are part of the TAPS because I wanted to show you what they are. So it says here, in the past 12 months, how often have you used any tobacco product? Now, if someone says never, you're done. But if someone says anything more than never, you should go on to the next question, which is, in the past 3 months, do you smoke a cigarette containing tobacco? And at this point, if someone answers yes, they get a point. And if they answer yes, the other questions are, in the past 3 months, do you usually smoke more than 10 cigarettes a day? They say yes, that's another point. And then the past 3 months, do you usually smoke within 30 minutes after waking? And that's a point. And that's it. Those questions are enough to give us a total score that will correlate with a zone of use. And this is how you score the TAPS. So if they score 0, they probably don't have risky use from tobacco. If they score 1, they likely are using tobacco, but they're not necessarily addicted to it. A score of 2 or 3, they're likely experiencing tobacco use disorder. So there you go. And you know what category your client falls into based on administering this tool. And if you go on with the rest of the questions, you can do the same thing for the other categories of alcohol and drugs. How do people report when they're using this tool? As you can see here, this study showed that the vast majority of participants said they were comfortable answering the TAPS questions. Most of them would be comfortable sharing the results with a doctor. So you may be seeing a person who experiences homelessness in a medical clinic. I forgot about that. Totally reasonable to use this tool, their tool as well. And as far as do they prefer if it's on a tablet or on a paper and an interview, it's kind of distributed differently there. So it doesn't seem like it's a big deal how you distribute this, whatever is most feasible for your setting. So that's the TAPS tool. Download it, use it in whatever format works best for you. And it takes maybe 2 or 3 minutes to administer. And then you have an evidence-based score that will tell you what category someone falls into. Adolescents, I recommend using the CRAFT tool because it also, like the TAPS, asks about multiple substances, not just tobacco. It's validated towards adolescents, 12 to 21. Again, this can be handed to someone on a piece of paper, or you can read the questions yourself. And let's look at these questions for the CRAFT. In the past 12 months, on how many days did you do the following? Drink alcohol, use marijuana, use anything else, or number 4 there, use tobacco or nicotine products. And anything greater than 0 is considered positive. And, you know, this is an example, by the way, of why we should use a validated tool, because when you ask someone during the past 12 months on how many days did you use a substance, that's a spectrum of answers people can choose from, as opposed to, do you use alcohol or smoke tobacco, yes or no? And that makes it very easy for an adolescent to just say no, even if they do use, because maybe they don't want to talk about it with you. But if you ask them on how many days during the last year have you done this, well, that's not so obvious what a positive score is. They don't necessarily know that anything greater than 0 means they should get some more questions. So this is an example of how these tools work. So if they do answer greater than 0, these questions ask about consequences. And with adolescents, you should ask them about riding in a car with someone who's been using, because that is the #1 cause of death among adolescents. And then it asks, do you ever use to feel better about yourself or relax? Do you use when you're alone? Do you forget things when you use? Does your family or friends ever tell you should cut back? Have you ever gotten into trouble? And a yes answer to any of these questions is a point. And on the back of the craft, at least if you use it from our website, this is how you score the craft. So a score of 1 or higher, you should do a brief intervention. If someone answers yes to the car question, you should discuss that because that's such a big issue. So the craft, again, it will assess someone's level of tobacco use, but it also addresses other substances. So like the TAPS is an all-in-one screening tool, and it's great to use with this population. Okay, that's screening. You can download these tools from the web. They're easy to find. So if someone is negative, you thank them for your time. But if they're positive, the SBIRT method says we should do a brief intervention. And the brief intervention we do for tobacco use is like the same we do for any other substance. You know, the treatment options are different or can be different. But when we explore someone's motivation to change a behavior around their substance use, we should use a model of motivational interviewing. And I'm going to teach this specific 4-step model on how to do that. But if you have another model that you've already learned and you like that, that's fine. They cover the same material. It just depends what you like. So in general, when we do brief interventions, they should employ motivational interviewing because that is the only evidence-based method of a conversation that is shown to help people change their behavior. Now, you can go to a 2-day training on motivational interviewing and get a certificate. I've done that. It's great. I recommend it. But you don't have to get such a specialized training in order to be effective. Studies show even 2 hours of training can make a difference. If this model I teach is totally new to you, I recommend watching some demonstration videos, maybe do some role plays, and keep practicing. The more you practice this with your clients, the better you'll get. The length of the brief intervention is not very important when it comes to how effective it is. It's the quality of the intervention that counts. We do know that multiple brief interventions over time are more effective than just one brief intervention, but it's not the length that's important. It can be done by anyone who's trained in this. You don't have to have a certain degree in order to be good at this. In fact, I found when I do these trainings that the higher level your degree is, the less likely you'll have experience doing this, at least in the medical world. As social work students and counseling students often have a background in this more than a physician does. So one way to introduce how we talk about this is to contrast it to a style of communication that is shown not to work very well. So if you're talking to a person experiencing homelessness, maybe in a shelter or in a clinic, exam room in a clinic, and you find yourself doing any of these, we know that people do not feel good when they're the recipients of what we call a directive style of communication. So if you find yourself explaining why the client should or patient should stop smoking, telling them how they should stop smoking, emphasize how important it is to stop smoking, and if they're ambivalent about stopping smoking right now, which most people will be, we all have ambivalence about giving up a behavior that we enjoy. If we react to that by trying to persuade them that they really should stop smoking, these are the words that people report feeling when they are the recipients of this directive style of communication. So trapped, defensive, not understood, not likely to come back and see you, uncomfortable, all things we don't want people to feel. Now, these may seem kind of obvious. I think a lot of people who are in the line of work of helping people experiencing homelessness can empathize with this population. But if you find that you're frustrated, maybe you really care about this person, they're clearly suffering some health effects from their smoking, and yet they're not ready to quit. Or you may judge yourself as not being a very effective counselor or social worker or professional because you haven't successfully convinced your client to quit, then you may fall into these traps. It's important to remember that your clients you work with are autonomous human beings, just like anyone, and they get to decide what to do and when to do it, and they have their own goals and values that may not meet your goals for them. So, and under that framework, just try to remember that you are not held accountable, and you should not hold yourself accountable based on your success in convincing your client to change their smoking. That's not how motivational interviewing works. We don't have a goal in mind for the client. We don't think of ourselves as successful or not based on have we succeeded in convincing the client to stop smoking. If we do that, then we will fall into these traps, because then you'll make the conversation about yourself and how effective you are. So it's important to remember that your only goal that you have when you do a brief intervention is to do it with as much quality as you can. And then when you're done, you move on. You move on to your next client or the next topic of conversation, because you have to do that. Probably if you see lots of people, but also because this is how behavior change works. The analogy people use in the MI world is that we all have seeds of change in our brain. And when someone does motivational interviewing with us, it waters that seed of change. So that's kind of the metaphor I would think of when we do this, is when we do motivational interviewing, we are watering someone's seed of change, and then they can let that sprout on their own. And then when we see them next time, they may be at the next stage of change. So anyway, that's a good way to approach this. So the kind of communication we want to use, what motivational interviewing falls under, is the guiding style. You are guiding this conversation. It is a two-way conversation, but you are facilitating it. And these are the principles that are important. So respecting your client's autonomy, their own goals and values. If they have an idea in mind, like a goal to change, maybe they are interested in cutting back their smoking or trying a nicotine replacement therapy, great, but we should also ask them how ready they are to meet that goal right now. They may not be ready right now. Most people are ambivalent about changing their behavior. We have to be comfortable with that. We have to roll with ambivalence, is the term people use. Even though we may want to see them concretely make a change, first, people usually react with ambivalence. And then if you're like a medical professional, or maybe you're an expert in local resources as a social worker, you are the expert probably in the setting where you're helping someone. But as soon as you do motivational interviewing, as soon as you want to talk about someone's behavior, the roles switch, and suddenly the client becomes the expert, because who else knows ourselves better than ourselves? Who else knows why we do things and why we don't do other things? We know the motivations better than anyone else. So whenever we talk about someone's personal behavior, it's important to recognize that they are the expert on that. Empathy means we can empathize with why someone may be engaging in a negative behavior that carries consequences, like smoking. We understand that there's probably some positive reasons why people smoke. And people don't really make a decision to change their behavior until they recognize what they don't like about it is beginning to outweigh what they like about it. And we can help them make that analysis, but it's important to empathize that people use substances for positive reasons. So we don't judge them for that. We can probably find behaviors in ourselves that are not healthy, or we need to do something better for ourselves, but we haven't committed to it. So that's why we don't judge other people. Maybe we don't exercise 30 minutes a day like we're supposed to. Maybe we don't floss our teeth every day. Maybe we use substances ourselves. We can all find a behavior probably that someone else might recommend that we change, but we're not ready to right now. So we don't judge people. And of course, we respect everyone who comes into our service setting. So what is MI? Just a couple slides here. It is a person-centered counseling style, and it focuses on people's ambivalence about change. That's what it is. And what we do when we do motivational interviewing is we help from the client's perspective understand and amplify that there's a discrepancy between their present behavior and what broader goals and values they have for themselves. So for a lot of people, that could just be living healthier. And that's a goal for someone. Through motivational interviewing, they may come to understand that there's quite a discrepancy between wanting to be healthier and smoking. And then through motivational interviewing, we help elicit statements from the patient that indicate a desire to change. Because when people hear themselves verbalize a reason to change, that has been shown to enhance motivation to change. So that's the other goal we're trying to do through MI. Now notice that these goals here do not include convincing your patient to change. That's not part of it. It's to create and amplify the discrepancy from their perspective and to elicit reasons to change. So how do we do this? I teach this model. There's another model out there called the 5 A's. And there probably are other models out there. And if you like those models better, feel free to use them. This is the one I teach. It's helpful to have a model when you're doing something new. It gives structure to the conversation. So this 4-step model, when someone is positive on that screening tool that you've used and you want to do a brief intervention, this is one way to do it. So let's go through each step. Well, you're going to have to raise the subject, which is probably easy to do if someone has answered questions from your screening tool, because you've already kind of raised the subject there. But you should say something like, thanks for answering these questions. This really helps me understand the role that tobacco plays with you. Is it okay if we look at your answers and we talk about your use some more? You can even use this to raise the subject of the screening tool. It's our policy here that we screen everyone for substance use. Is it okay if I ask you some questions on this form about substance use? Asking permission is not just a formality. It's an important step because it sends a message, and that message is, I want to embark on a two-way conversation with you about your substance use. As opposed to, I'm going to be telling you what I think you should do. So asking permission is a great way to send the message that this is a two-way discussion. Now, if someone says, no, I don't want to talk about it, you could say something like, okay, maybe next time. That way you're leaving the door open for a future conversation, even though you're respecting your client's wish to not talk about it today. But if they answer yes, then the next thing you should do is just explain a little bit about your role. Why are you having this conversation with your client about substance use, whether it's tobacco or tobacco plus other substances? I would say something like this. So thanks for giving me permission to talk about your tobacco use. Just so you know, I'm not going to ask or advise you to stop or change your use in any way that you don't want to. Instead, my role is to understand what your goals and visions are for your future, and I can be a resource. I can share information with you so you can improve your quality of life on your own terms and on your own timeline. How does that sound? So this is where you should be coming from, and there's no reason to keep it a secret. Just let them know why you would like to have this conversation. This will set a foundation for a much more productive conversation because it just makes it plain where you're coming from. Because your client, if you don't say something like this, might expect that you're going to take a different approach. They're not sure what to expect. So why not be transparent about it? So you've got permission, you've discussed your role. The next thing I would do is ask the client, it's great that you filled out you answered these questions on this questionnaire here, but I'm curious, in your own words, can you tell me the role that smoking plays in your life. Give your client a chance to describe their use, because they may disclose things about their use or other substances that play a role in their life that we're not asked about on the screening tool. The next step is your client deserves to know the facts, even if they know some of the facts already, even if they're not ready right now to do anything about the facts, but they should know them. This is where you are a resource. And one fact is what their score is on the screening tool. There's no reason to keep that a secret. You can say, your answers here, they get points, and when I add up these points, I get a total score, and that total score puts you in a category we call tobacco use disorder. And what does that mean? Well, it means some people who use tobacco in this way start to experience some repeated negative consequences. And that means that the nicotine, the drug that's in tobacco, might be impacting your brain in a way that makes it harder for you to change your smoking, even if you wanted to. And most people who are in this category need help in order to change their smoking. And there's different types of help, and we can talk about that. But that's what this score means, that it probably means you're experiencing some level of addiction to nicotine. Or your score indicates that you may not be addicted to tobacco use, but you are using at a risky level, which means that over time, you're more likely than someone who doesn't smoke to run into a big number of health problems. So that's why it's called risky. So that's an example, just share what their score is on the screening tool. And then if you're in a medical setting and they've come in to see you because they have a cough or they're not breathing well or some kind of issue related to smoking, they should know that there's a correlation there. Or maybe they've had a stroke in the past, or they're experiencing heart disease. Anything that is associated with tobacco use, you should share that with them. Something like, one of the things we know that increases the chance of having a stroke is smoking. Do you think your smoking has anything to do with the minor stroke you had last year? You can raise it as a question. And then in general, you should share what the risks are. And you can do that by handing them a pamphlet, or you can just read them off yourself. But everyone should know, if they're smoking, what the risks are over time. And there's a long list of morbidity. And then when you're done sharing this information, you should ask them, so what do you think? I've just shared with you all this info about the risks of smoking. What do you think about how smoking impacts you? Remember, this is a two-way conversation, so they get to share their input too. And if it doesn't match what you think about the risks of their smoking, that's okay. The goal here isn't, again, to persuade them. It's to be a resource to them. And even if they don't think that their smoking really impacts them negatively right now, after later that day or the next day, when they're thinking about this, they may think about their smoking in a way they haven't before because of this conversation with you. Not because you convinced them, but because you have been open about what the risks are. You've shared information with them. Traditionally, in some SBIRT protocols, it used to be that you're supposed to give a recommendation or advice. You're supposed to say something like, I recommend to stop smoking, or it's my advice to stop smoking, which can seem maybe rather innocent and straightforward. But there's a couple problems with that. One is it's unnecessary. If you share the information about the negative risks of smoking, that's what's important. There's no reason to frame it as a personal recommendation or your advice, because if you do that and your client is not ready right now to change their smoking, well, does that mean they're letting you down personally because you framed it as a recommendation? Why not just avoid that whole mess, because that invites stigma. People don't feel good when they're not living up to your recommendation for them. So just share the information about the risks are. And then when people are addicted to a substance, they feel often trapped, like they just don't see a way out of their use, or their worldviews just are very narrow around continuing to use the substance. So if you recommend, like, okay, I recommend you stop smoking, and they're not ready to, well, that just doesn't do anything for them. What we want to do is broaden their worldview of what's possible. And so we want to brainstorm with them the options of how to reduce harm from their smoking, which includes getting help to stop smoking. But we want to expand the spectrum of options that they can choose from, even if they're not ready right now to stop smoking. Maybe they're ready to cut back or at least count the number of cigarettes they use each day, or try to see what it means to not smoke for a couple days or a week, or maybe just see someone, a counselor who can specialize in substance use counseling, even while they still smoke. They are willing to do that. So we want to stay away from just saying this dichotomous, you need to stop smoking or not. Okay, so the next step is how do we enhance someone's motivation? Well, we do that by first asking them to tell you what they like and don't like about their tobacco use. And this could be a surprise question from someone, like, why are they asking me what I like about my tobacco use? But the reason is we want to get them to analyze the pros and cons, because people will not change their behavior until they begin to understand that the consequences are beginning to outweigh what they like about it. The other reason we do this is it helps us empathize and build rapport with our client, because we understand as a fellow human being why people use substances. There have to be positive reasons why someone uses a substance. Otherwise, people wouldn't use substances. So what we should say is something like, I'm curious, could you tell me what you like about smoking? And then when they tell you, then you should also say, is there anything that worries you about your smoking? Is there anything that you don't like about your tobacco use? So you're getting them to analyze what they like and don't like about it. And people often engage in risky or negative behaviors in an unconscious way. They don't really make an analysis like this. So this is what a brief intervention can do, is get someone to step back and kind of look at their behavior in a way they probably haven't done before. So when we ask people what they like about their use, keep in mind you'll help connect and empathize with your clients if you understand why people use tobacco. There's a number of reasons. The feeling of having nicotine in your body if you become adjusted to it. For some people, that alone is why they smoke, or they just don't want to go through withdrawal. For some people, it really helps them relax. It can be a social tool where people are smoking together. These are not reasons that excuse smoking. That's not the point. The point here is to understand and empathize with your client why they do smoke. And then I would summarize what you hear. This is one example. So on one hand, I hear you say that what you like about your smoking is that it makes you feel relaxed and it reduces your anxiety, at least in the short term. But on the other hand, you wonder sometimes if you're becoming addicted to cigarettes and you don't like it when you can't smoke inside the shelter or other places. Is that correct? So you want to summarize what you hear. And this is what they're doing. They're weighing the pros and cons. So after you've done this, then the next thing you should do is just ask the client, where do you want to go from here in terms of your smoking? We want to elicit a goal of some kind, no matter how small. We want to elicit a goal, and there's different ways of asking this question. You can say, over the next few weeks, what would you like to see happen for yourself? What would you like to do about your tobacco use? Where would you like to go with your use? I know of a number of resources I can put you in touch with. Here's a number of treatment options, but you leave it up to your client to decide what they want to do. And goals are important. The more you can get your client to define the goal in a concrete way, as opposed to, I don't know, I don't want to cough anymore. I just want to be healthier. Well, that's a good goal, of course, but it's kind of a big abstract goal. We want to get them to define a feasible goal that they can do in a time frame. Like, for example, if they're interested in trying a nicotine replacement therapy, great. When do you think you would want to do that? Oh, I want to do that within like a week or a month or whatever it is. Whatever the goal is, or maybe, I can cut back. I'm gonna try smoking only, 5 cigarettes a day instead of a pack. And okay, great. How long do you want to try that for? Whatever it is, it should be a positive goal. It should reduce harm or improve the quality of life. It should be doing a time frame, and it should come from them as opposed to you. However, if your client really has no ideas on a possible goal and you have some ideas, with their permission, you can share them with them. You can say something like, when I talk to other clients about tobacco use, they've shared with me some goals they came up with. Would you like to hear them? And with their permission, you can share them. So like I said before, if they don't really have small concrete goals, maybe they have big ones, you can say something like, okay, so you want to be healthier, you don't like coffee, and you want to be able to be more active. So if that's the goal we put up here, what steps could you take to get to that goal? What would be the first step towards just being healthier? So we're looking for concrete, achievable goals, doable in a time frame that can lead to a big goal like living healthier. Some examples of goals: maybe they're interested in reducing their use or abstaining or getting help. They've never counted their cigarettes before. Maybe they're interested in doing that. Maybe they're interested in nicotine replacement therapy. Maybe they're interested in getting just regular medical care, even though they're going to continue to smoke right now. They are open to improving their life in other ways around their health, like seeing a doctor. They're not ready to quit smoking forever, but maybe, for a couple weeks to see what it's like. Maybe they'll think they'll smoke less if they avoid areas where their peers smoke. And then maybe they're interested in vaping. It's not a common option for a lot of people experiencing homelessness, but it is a harm reduction goal of vaping instead of smoking. So these are just some examples of client-driven goals around tobacco use. Now, if they have a goal in mind, the next thing you should do is gauge how ready or confident they are to achieve that goal, because just because someone has a goal in mind doesn't mean they're ready right now to achieve it. So it could be the first step that you really get out of this first conversation is they have a goal in mind, but they're not ready right now to do it, which means next time you see them, if you have the advantage of having an ongoing relationship with these clients, they may be ready to achieve this goal next time. But how do we gauge their readiness? We use the readiness ruler, and that's because it will help you elicit reasons to change. How do we do that? We ask them, on a scale of 0 to 10, with 0 being you're not ready at all right now, to count how many cigarettes you use in a day, and 10 being really ready, what number would you pick? And when they give you a number, what you're supposed to do here is ask, why not a lower number? Meaning, let's say your patient or client wants to count their cigarettes. So you say, okay, so you picked a 4 on how ready you are. You could have picked something lower, like a 2 or a 3. Why did you think you picked a 4? Or maybe you picked a 10. So you picked a 10. You're really ready right now to change your smoking. Why do you think you picked a 10 instead of just like a 7 or an 8? Now, when someone answers this question, they will most likely verbalize a reason to change. So they may say something like, I guess I picked a 4 instead of something lower because I know I'm coughing more lately, and I don't walk around as much as I used to. I just kind of sit, and I don't really like that, and this probably has something to do with my smoking. Or I'm a 10 instead of like a 7 or an 8 because I had a friend go to the hospital and he died from lung cancer and he smoked. I used to smoke with him and I don't want to end up like him. Well, whatever the reason is, by getting them to verbalize desire to change, when people hear themselves express desire to change, that has been shown to enhance their motivation to change. So that is kind of this little trick we do here when we use the readiness ruler. We're not only getting a number on a scale of how ready they are to achieve a goal, we're also asking them why not a lower number. So that's the readiness ruler. So if your client has a goal in mind, but they're not ready right now to achieve it, maybe they're below a 5 on the readiness ruler, then you can wrap up the conversation. You could say something like, thank you for being honest with me. It sounds like you have this goal in mind of changing your tobacco use. You're not very ready right now to achieve that goal, but I'd like to see how you feel, next time I see you. But if they do sound ready to achieve a goal, whatever it is, you should ask them, what plan could you put into place, and maybe with my help, of achieving your goal? You're interested in nicotine replacement therapy. I know how to get you in touch with someone to access that. When do you want to do that? What's your plan? A plan, people are more likely to achieve a goal when they come up with a plan, and the plan should come from them. That's why we ask them. However, if they don't have any ideas on what a plan could look like and you have some ideas, it's just a matter of saying, again, when I talk about this with other clients, they've come up with some plans. Can I share them with you? Or I have some ideas. Would you like to hear them? We want to frame it as asking permission because we don't want to appear like we're directing them on what we think they should do and how we think they should do it. So if they have a goal and they have a plan, then you can ram up just by saying, well, great, I'd like to hear how this goes. Next time I see you, maybe your plan, you had a really easy time carrying it out and you reached this goal. Maybe you have a different goal in mind. Or maybe your goal was really hard and the plan didn't work and we could brainstorm a different plan. Whatever happens, I'd like to hear how it goes. So if you're in a position to have some kind of follow-up, whether in a medical setting to schedule an appointment or in a service setting of another kind where you'll see that client again, even if you don't have an appointment or a date in mind, just leave the door open to a future conversation. Because in the medical world, this is called follow-up, but you can also call it like just checking in. And when you can check in with someone over time, it should be a collaborative tracking of client-selected goals. So they may come up with new goals or new plans, but the point here is, like with any substance use, you want to check in with them with their permission whenever you see them. You're always a resource. You can share information about how to connect people with resources, share information about risks, and see what new goals they have in mind. So ultimately, the take-home message here is when we do this 4-step model is the more responsibility, autonomy, and respect people feel they have, the more they will step up and forge their own pathway. We defer to their wisdom about themselves. You as a professional are a valuable resource to them and it can help them forge their own pathway, but it is their own pathway. Now remember, most quit attempts at smoking, if they're done alone, have a very small chance of succeeding. They're greatly enhanced when they have help, and that's what you are. You are help. These are the 4 steps that we just went over. On the SBIRT Oregon website, we have a reference sheet, which is something you could use to help you when you do a brief intervention. But again, if you find a different model that you like on how to do MI with someone, that's totally fine. And then stages of change. I kind of commented before how people move sequentially through stages of change. And this is the model of change that a lot of people use. This is important to keep in mind because not everyone will jump to the maintenance stage of change based on your one brief intervention. Someone may come to you, not even when you're talking to them, they may not even think of their smoking as a problem to begin with, let alone want to do anything about it. So we would probably say they're in the pre-contemplative stage. But if you do a good quality brief intervention with them, what's likely to happen is they won't necessarily be ready to change their behavior, but they might now think about their smoking in a way they never have before. And so we would call them probably in the contemplative stage. And that's what brief interventions do, really, is they help someone move to the next stage of change until they reach maintenance. Relapse, and that term actually is out of fashion nowadays. We say return to use. So I need to fix the slide. But return to use is part of this wheel also. So just know that when you talk to someone about their tobacco use, they could fall anywhere along this wheel of change. Okay. So I gave you a structure, a 4-step model on how to do this. There's also skills involved in motivational interviewing, and you may already be familiar with some of these skills, but I want to go over them anyway because they are essential when you do this. And the acronym, of course, is OARS: open-ended questions, affirmations, reflective listening, summaries. So when you do a brief intervention with someone about their tobacco use or any substance use, try to use these skills as often as possible. When we ask open-ended questions, we're more likely to get important information from a client than a yes or no question. So it invites the client to tell their story. It's important to listen to them when they answer that. Try to use them as often as you can. And what are some examples? Instead of saying, "Are you in pain?" That's a yes or no question. You can say, "How do you feel?" Or how often do you use tobacco? You could say, what role does tobacco play in your life? Don't you want to stop smoking and be healthier? An open version of that would be, what advantages do you see in changing your tobacco use? So good examples of open-ended questions. Affirmations, these are really important because in order for someone to change their behavior, it requires a certain level of self-confidence or self-efficacy. And how do we build that self-confidence with someone? Well, we take the opportunity whenever it presents itself to affirm any kind of positive trait with a client, no matter how big or small. When we hear from another person, especially if they're a professional, that they're saying something about us that is positive, that helps build our self-esteem, our self-confidence. So what are some examples of that? Well, even if they're smoking, if they made a medical appointment, for example, about something, you can say honestly, like, "Oh, you made this appointment and you showed up on time, so you must care about your health." Now, that's a great affirmation because if they care about their health, then they might look at their smoking in a different way. Or, so you've tried stopping smoking in the past and you've returned to smoking. So this is hard work you're doing. You're continuing to try to stop smoking. This is hard work. So you're acknowledging that they're doing something that's hard. Oh, you were successful last year. You didn't smoke for a month, or you tried seeing a counselor, so you were able to do that. Oh, that's a great idea. Or you're clearly very resourceful. I didn't think about that. Or not everyone's willing to talk to me honestly about their substance use, so I really appreciate that you're able to do this with me. So anything positive about your client, as long as it's genuine, big or small, you should affirm that. How do we convey to the client that we are hearing them, we're listening to them? We should reflect back what we hear. This isn't maybe an obvious skill, but it's really important. People will have a better rapport with you and trust you and come back and see you if they feel heard, that you understand their worldview, even if your worldview is different. Some examples of that, maybe they say, "I don't think I'm really addicted to cigarettes." Okay, so being told you're addicted to tobacco doesn't seem right to you. Now, as a professional, you may know from the screening tool that they likely are experiencing a tobacco use disorder, and you don't have to compromise that opinion. That's your opinion, but you don't have to convince your client to come around to your opinion. You can reflect back what they were telling you without compromising what you believe for yourself. Client says, I've never not smoked. It's just part of who I am. So smoking feels normal to you. I don't like having to smoke in places away from everyone. So feeling part of the group is important to you. I know I shouldn't smoke, but I haven't stopped yet. So you know all the reasons not to smoke, but it's been hard to find the motivation to stop. So examples here of how we convey that we are hearing the client by reflecting back what we think they said. Now, the last skill here is summarizing. This is an important skill when we're not sure what to say next, or maybe our client, like many clients do, they're not conveying the information to us in a linear way that we might want them to because we're taking notes or whatever. They may share information with you through telling stories, or they go off on tangents, which is totally fine. But to bring both people back to focus here on the conversation, we can summarize. So you take a break, you step back, and you summarize what you think you've heard, and then you can go on to what you want to say next. So if during a conversation with your client, these little tidbits of information come out at different points of time, and you want to kind of get back to what you want to say next, well, you can do this. You can say, okay, so if I hear you right, it sounds like you're not interested in getting help right now for your smoking. There's a challenge in that you'd have to find transportation to this place where you get the therapy, and you're worried about not smoking and how that would feel. But on the other hand, you think you'd be healthier in the long run and your relationship with your kids might improve. So is that right? Did I hear you right? So you're summarizing in order to kind of bring the conversation back into focus. So those are OR skills. We've talked about what screening tools to use, the TAPS and the CRAFT. We talked about how to do a brief intervention. I recommend getting as much practice as you can, especially if you're like a counselor or a medical professional where you talk about behaviors in general. This model works. It's the same model to use whenever you want to talk about any behavior: diet, exercise, substance use, adhering to a treatment plan, using protection during sex, flossing your teeth every day, whatever it is. This model we just went over is how we talk about it. And so I recommend, here I am giving a recommendation. Don't let me down personally. I recommend getting practice with that. But some of your clients will be ready for treatment, and I want to talk about that. But first, I want to say it's not likely, based on your first conversation with someone who uses tobacco, that they will be ready for treatment, whatever that treatment modality is. This is a big survey that SAMHSA does every 2 years. They ask people a lot of questions. And as you can see here, when they ask people who did not receive treatment, even though they had a substance use disorder, you can see the huge majority of them felt that they do not need treatment. So keep that in mind when you're talking with someone who probably has a tobacco use disorder. They're probably not going to be ready right now to accept treatment because they're pre-contemplative. They don't even believe they need treatment, let alone how to access treatment. So you will probably help your client move to that next stage of change rather than convince them to get them to treatment. And what does that mean? When we don't focus solely on treatment, that means we are essentially doing harm reduction because we're helping people wherever they fall along those stages of change. Or the motto in this harm reduction movement is called, we meet the client where they're at. Instead of us imposing what we think the best plan of action is, we find out where they're at, what they're ready to do, and we help them at that place. And that means we don't help just that 2.5% of people who believe they need treatment. We can help all sorts of people when we meet them where they're at. And that essentially is what harm reduction is. A few slides about stigma here. I think for people who work with this population, people experience homelessness, you probably have more respect and less stigma towards these clients than maybe the general population, because that's why you went into this line of work. However, it's important to know that whether it's the substance use or the status of experiencing homelessness, stigma is a big deal. If we feel stigmatized by society, by professionals, by friends or family, it diminishes our self-worth and self-esteem. And that's a problem, because in order to change behavior, we need a certain level of self-worth and self-esteem. People who feel stigma because of their substance use or being homeless, that stigma could inflict greater psychological harm than the actual chemical impact of the substance itself. We're less likely to access treatment, again, if we feel stigmatized. And the really tragic paradox of this is, for some people, when they feel stigmatized and they have low self-esteem, one way to cope with that or to escape from that temporarily is to get high or use the substance, whatever it is. And of course, even though that may be a short-term way to deal with it, it's a downward spiral, because that's the same behavior that is behind the stigma to begin with. So it can just get worse and worse. So watch out for stigma, whether it's within yourself or your colleagues. Where does stigma come from? Whether it's towards someone's substance use or their status. When we find ourselves beginning to believe that someone has caused their behavior, their addiction, or we believe they should be able to control their addiction, that's the root causes of feeling stigma towards someone. And the kind of language we use can either mitigate stigma or make it worse. So just a few slides here on, for example, if someone begins to believe that someone has caused their addiction, remember of all the things we know from research of the risk factors behind this. So if we look at substance use disorder as the main problem and the consequences there are on top, the branches of the tree, well, we know a lot about the risk factors. You know, people are more likely to experience a substance use disorder or experience homelessness if they've had a history of these things down there. So a history of abuse, poverty, early exposure to the substances, absence of social support. To live in this country as a person of color or LGBTQ, or to come from a history of poverty, all risk factors that are environmental, structural, and really have nothing to do with the individual making choices to begin with. So we have good evidence right now on what is associated or perhaps causes addiction and homelessness. So this is an environmental structural problem, not an individual one. But when it comes to an individual and they're engaging in a behavior, remember that someone living with addiction, they can't necessarily on their own, or this is highly debatable, can someone control their cravings and their behavior? Well, it's controversial, because what is a substance use disorder? It's a brain disorder. And that's well studied. It's not a moral failing or a lack of willpower. It's our brain working differently and telling us different things than someone who's not experiencing addiction. So how much free will and capacity people have when they're alone and the decisions they make, it's hard to know. Because their substance use has impacted their brain in a way that makes it harder for them to really carry out conscious choices without getting help. Language. When we work with this population, the language we use with them, as well as the language we use about them with our colleagues when we talk about our work, is important when it comes to either making stigma worse or mitigating stigma. These are recommendations that came out of the White House in 2017. I want to share them with you. So if you're working with someone who smokes, maybe they also inject drugs. Instead of calling them an injection drug user, we try to use language that is person first. And even if someone's life is clearly, repeatedly, negatively impacted by their substance use, and their lives tend to revolve around getting the substance, we need to remember, in order to have productive, genuine relationships with our clients, that even if they're living with addiction, we should understand how they are more than just their substance use. We should be able to relate to them in addition to their substance use by knowing that maybe they feel strongly about a community that they're part of, or their pet, or a neighborhood that they live in, or a family member, or a local sports team. Whatever it is, we should know our clients in ways that are more than just their substance use, even though we may be focusing on that when we apply SBIRT. So that's why we use person first language. So instead of saying abuse, dependence, drug habit with a DSM-5, now we say substance use disorder. It's less stigmatizing language, it's more accurate. Instead of calling someone an abuser, an addict, or an alcoholic, we say it's a person with a substance use disorder. If someone's continuing to use, are they dirty because they're not clean and sober? Why not just say person in recovery? If someone uses a needle and we call that needle dirty, that means they made it dirty. Why not just say used or new needles? If someone gets a drug test, why not call the results positive or negative instead of dirty or clean? Less stigmatizing language. And I mentioned before how we're kind of moving away from the term relapse. Instead, we say return to use. There is stigma around that term relapse. And then instead of calling a population high risk, we could say, individuals at risk of whatever it is, if they're injecting drugs, acquiring HIV, Hep C, etc. So language is really important. So I'm going to end a little early in case there are questions or comments, but the take-home messages here are, if you want to address tobacco use with people experiencing homelessness, use the TAPS and the CRAFT screening tools. They're quick, they're validated, they'll give you good information. And then if someone's positive, practice and perform high-quality brief interventions. You can do this on your own, or you can go get more training. And then make sure you can help the maximum number of people you can through adopting a harm reduction philosophy by meeting your clients where they're at. And with that, I thank you for your time.
Thank you so much, Jim. I haven't had any questions come in yet, but we do have some comments. Linda said, thanks for the examples of what to say specifically. That was excellent. And Shannon said, reflecting has helped clarify when I misunderstood what my patient was saying and led to a great conversation.
Great, glad to hear it.
All right. And then everyone's just saying thank you. So it doesn't seem like there are any questions. One person did ask if they would be able to receive the slides. So if you're willing to send a PDF of those, then
Yeah.
I can send those out to everybody. Okay, great. Well, thank you again, Jim, for your time today. Thank you, everyone, for joining us. If you stick around for just a quick second, I'm going to go over some last minute housekeeping items. We would like to remind all participants that the PDF of today's PowerPoint, along with the recording of today's presentation, will be uploaded to the webinar library located on IREDA's website sometime next week. Once we have these resources posted, a link will be sent out to all of today's webinar registrants. I now want to remind you of our evaluation CEU process. You will receive several follow-up emails from us. The first email will include a link to the evaluation, and the second email will include step-by-step instructions on how to obtain CEUs. Please note that it will take 48 hours, up to 48 hours for your CEUs to become available because we have to cross-check attendance records with WebEx. We would like to request that you fill out our evaluation. It should take no more than 2 minutes of your time. Again, we want to thank everyone for taking time out of your day to participate. If you have any questions at all, please email us. The email address is info@ireta.org. And with that, I will conclude today's webinar. Thanks
Thanks,
again,
everyone.
Jim.
Bye now.